Hello everyone, and welcome back to another chapter of Advanced Pathophysiology. Today we talk about chapter 47, Structure, Function, and Disorders of the Integument. We'll be reading the entirety of the chapter. Again, my pages may not line up as yours, but we'll cover all of it. So, we'll jump right in. The skin covers the entire body and is the body's largest organ, accounting for roughly 20% of the body's weight. Combined with the accessory structures of hair, nails, and glands, it forms the integumentary system. The primary function of the skin is to protect the body from the environment by serving as a barrier against microorganisms, UV radiation, loss of body fluids, and the stress of mechanical forces. The skin regulates body temperature within a very narrow range and is involved in immune surveillance and the activation of vitamin D. Touch and pressure receptors provide important protective functions and pleasurable sensations. The commensal microorganisms of the skin protect against pathologic bacteria. So, structure and function of the skin. Layers of the skin. The skin is formed of three major layers: the superficial or outer layer of the epidermis, a deeper layer of dermis, and the subcutaneous layer or hypodermis, the lowest lying layer of connective tissue that contains macrophages, fibroblasts, fat cells, nerves, fine muscles, blood vessels, lymphatics, and hair follicle roots. Each skin layer contains cells that represent progressive stages of skin cells differentiation and function as the skin grows. These are summarized on table 47.1. So here we're taking a look at different layers of the skin. As always, if there's any kind of anatomy, physiology, or if I'm going too quickly, hit that pause button. Here is a great spot to get a quick review of your anatomy. So hit pause here, take a look at everything, and we'll continue on. Here is table 47.1, the layers of the skin. Again, a good spot to pause so you can read between the different cell types, characteristics. I'll keep going. So here's another good spot. It'll cover everything in that box. The epidermis. The epidermis is a defense barrier that continually renews itself by shedding the superficial layer of stratum corneum. It is formed primarily of keratinocytes embedded in lipid matrix. These cells are named for their substance they produce. Keratinocytes produce keratin, of scleroprotein that provides protection from mechanical stress. Keratin is the main constituent of skin, hair, and nail cells. The thickness of the epidermis varies from 0.0 millimeter on the eyelids to 1.5 mm on the palms of the hands and soles of the feet, and averages about 0.12 mm. New cells formed in the basal layer move upward and differentiate, forming the spinous layer. Together, they form the germinative layer and ensures continual renewal of the skin. The cells enlarge and then become flattened, stacked, and cornified as they ascend to the skin surface. Cornification or keratinization prevents dehydration of deeper skin layers and loss of body water. The average turnover of the epidermis is about 30 days. The epidermis has three additional types of cells that facilitates its functional characteristics: your melanocytes, Langerhans cells, and Merkel cells. The melanocytes are usually located near the base of the epidermis. They synthesize and secrete the pigment melanin with exposure to UV light in response to melanocyte-stimulating hormone. Melanin in the epidermis provides a shield against UV radiation and determines skin color. Vitiligo is thought to be an autoimmune-related loss of melanocytes, resulting in the depigmentation of patches of skin. Langerhans cells migrate to the epidermis from the bone marrow. Langerhans cells and dermal dendritic cells initiate an immune response by presenting processed antigen to T cells, thus providing a defense against environmental antigens. Merkel cells are associated with touch receptors and function as slowly adapting mechanoreceptors when stimulated by deformation of the epidermis. The dermis. The dermis is 1 to 4 millimeters thick and is composed of 3 types of connective tissue: collagen, elastin, and reticulin, and a gel-like ground substance. The haphazard arrangement of connective tissue allows the skin to be mobile and to stretch and contract with body movement. Hair follicles, sebaceous glands, sweat glands, blood vessels, lymphatic vessels, and nerves are contained in the dermis. The cone-like projections of the papillary dermis interface with the epidermis. The papillae provide texture to the surface of the skin by forming reed pegs. The cells of the dermis include fibroblasts, mast cells, and macrophages. Fibroblasts secrete the connective tissue matrix and collagen. Mast cells release histamine and play a role in hypersensitivity reactions in the skin. Macrophages are phagocytic and participate in immune responses. Histiocytes are macrophages that reside in loose connective tissue and phagocytize pigments and debris of inflammation. That leads us to the subcutaneous layer. The third layer of the skin is subcutaneous tissue, your hypodermis, and consists of an adipose tissue. The lobules are separated by fibrous walls, septa of collagen, and large blood vessels. Dermal collagen is continuous with the collagen found in the subcutaneous tissue. Dermal appendages. The dermal appendages include the nails, hair, sebaceous glands, and the acrine and apocrine sweat glands. The nails are protective keratinized plates composed of 6 structural units: the proximal nail fold, the eponychium, or cuticle, the matrix from which the nail grows, and its nail root, the hyponychium, the nail bed, the nail plate, and the paronychium, the lateral nail fold. Nail growth is continuous throughout life at a rate of about 1 mm or less per day. So again, good spot to hit that pause button, and you can read over how and what the structures of the nail are. Hair follicles and sebaceous glands are integrated units. Hair color, density, grain, and pattern of distribution have considerable variability and depend on age, gender, and race. Hair follicles arise from the matrix, located deep in the dermis. They extend from the dermis at an angle and have an erector-pili muscle attached near the mid-dermis that straightens the follicle when contracted, causing the hair to stand up. Hair growth begins in the bulb, with cellular differentiation of the stem cells occurring as the hair progresses up the follicle. Hair is fully hardened or cornified by the time it emerges at the skin surface. Hair growth is cyclic, with periods of growth and rest that vary over different body surfaces. Hair color is determined by melanin-secreting follicular melanocytes. The sebaceous gland opens onto the surface of the skin through a canal. They are found in greatest number on the face, chest, and back. Modified glands are found on the eyelids, lips, nipple, glans penis, and prepuce. Sebaceous glands secrete sebum, composed primarily of lipids, that oils the skin and hair and prevents drying. Growth of a sebaceous gland is stimulated by androgens and their enlargement is one of the early signs of puberty. The Apocrine sweat glands are distributed over the body, with greatest number in the palm of the hands, soles of the feet, and forehead. These secretions are important for thermoregulation and cooling of the body through evaporation. The apocrine sweat glands, located in the axillae, scalp, face, abdomen, and genital area, are fewer in number and have very limited proven function. So, your blood supply and innervation. The blood supply to the skin is limited to papillary capillaries, or plexus, of the dermis. These capillary loops arise from the subpapillary plexus that is supplied by a deeper horizontal cutaneous arterial plexus. Branches from the deep plexus supply hair follicles and sweat glands. A papillary network of veins drains the capillary loops. Arteriovenous anastomosis in the dermis facilitate the regulation of body temperature. Heat loss can be regulated by varying blood flow through the skin. By opening and closing the arteriovenous anastomosis in conjunction with evaporative heat loss of sweat. The sympathetic nervous system regulates vasoconstriction and vasodilation of hair-bearing skin through alpha-adrenergic receptors. Non-hair-bearing skin of the palms, soles, and lips is innervated solely by sympathetic vasoconstrictors with passive vasodilation. The lymphatic vessels arise in the papillary dermis and drain into larger subcutaneous trunks, removing cells, proteins, and immunologic mediators. Aging and the skin integrity. Many age-associated changes in the skin are generalized and readily observable. Genetics and cumulative environmental factors include UV radiation from sun exposure, inflammatory responses, tobacco smoke, and gravity. Contribute to cutaneous changes with aging. Structurally, the skin becomes thinner, less elastic, drier, and wrinkled, with a change in pigmentation. There is a loss of adipose tissue volume, particularly in the face. The cellular alterations contributing to the changes include a flattening of the dermo-epidermal junction with a shortening and decrease in the number of capillary loops. There are fewer melanocytes, resulting in decreased protection against UV radiation. A significant decrease in the number of Langerhans cells reduces the skin's immune response with aging. The thickness of the dermis also decreases, with loss of extracellular matrix and elastic fibers, and accounts for translucent, paper-thin quality of the skin. Loss of the reed pegs gives the skin a smooth, shiny appearance. As the skin microcirculation ages, there is decreased vascular compliance and loss of vasoreactive responses with decreases in skin blood flow. Temperature regulation is comprised in older adults, with an increased risk for heat stroke and hypothermia. Loss of cutaneous vasomotion and subcutaneous fat, reduced vascularity, and decreased acrine sweat production are contributing factors. The decreased vasculature and lymphatic drainage contribute to loss of barrier protection, and the atrophy of apocrine, and sebaceous glands promotes dry skin. Loss of elastin fibers is associated with wrinkling. Collagen fibers become fragmented, and fibroblasts decrease in number, resulting in a decreased ability of the skin to stretch and regain shape. Decreased cell proliferation, diminished blood supply, and depressed immune responses can delay wound healing in aging skin. Changes in hair color and distribution also occur. Graying is caused by loss of melanocytes from the hair bulbs, and thinning occurs from loss of stem cells and a gradual decline in the number of hair follicles and growth of finer hair. Epidermal cells change shape, and the barrier function of the stratum corneum is reduced. There is increased permeability and decreased clearance of toxic oxidative substances from the dermis that are performed from exposure to environmental toxins and UV radiation. Pressure and touch receptors and free nerve endings decrease in number and reduce sensory perception. So tests of skin function. Initial diagnostic evaluation of skin disorders are completed by gathering historical information, performing a physical examination, and observing the distribution and characteristics of the presenting lesions. Additional diagnostic studies are summarized in the following table. A great spot to hit pause. So here you see the summary of the skin diagnostic procedures. So you have your tests and their purposes. And it's got a full list of it. Pardon. So if you're not familiar with different kinds of skin tests, here is a good spot to write some flashcards. Clinical manifestations of skin dysfunction. So we're starting off with some lesions. Lesions of the skin are readily observable and easily assessed for distribution and structure. Identification of the morphologic structure, including a differentiation between the primary and secondary lesions and the general appearance of the skin, is critical. The physical examination is combined with a thorough health history, is essential to identifying the underlying pathophysiology. The following table describes and illustrates the primary lesion of the skin, followed by a table that describes and illustrates the secondary lesions of the skin. Special skin lesions are described in the following table after that. So we got 3 tables that we're going to be hitting the pause at, so that you can look at different types of lesions. So here we're looking at a macule, followed by a papule, then we've got skin patches. Now we've got some plaque, a wheal, a nodule, and a tumor. Vesicles, a bulla, a pustule, a cyst, telangiectasia, followed by secondary skin lesions. Here we've got some scaling or scale, followed by lichenification, a keloid. Again, good spots, always hit pause, read them over so you can see where you would find them. I really should be reading their examples. I'm half tempted to go back to the top and start over, to be honest. But yeah, hit pause and at least read some examples. Especially, you got your scars, your excoriation, fissures, erosions, ulcerations or ulcers. And remember, we've got different stages for those. Atrophy. And now I think this is the last table here that they were talking about, special skin conditions, where I guess they don't have pictures for it. A comedone, a burrow, petechiae, and purpura. So, pressure injury. Pressure injury is localized damage to the skin that results from unrelieved pressure, shearing forces, friction, and moisture. Pressure that consistently interrupts arterial and venous blood flow to and from the skin or deeper tissues is the most significant cause. The term decubitus injury refers to a pressure injury that results when an individual lies or sits in one position for a long time. Mucosal membrane pressure injury is related to injury caused from use of medical devices, such as endotracheal tubes. Risk factors for pressure injuries are summarized in the following box. So anyone who's a nurse is very familiar of pressure injuries. Unfortunately, for anyone who is not a nurse, these are good spots to hit pause. Pressure injuries usually develop over bony prominences, such as the sacrum, heels, ischia, and greater trochanters. Continuous pressure on tissue between the bony prominence and the resistant outside surface distorts capillaries and occludes the blood flow and oxygen supply. Individuals with darkly pigmented skin are at greater risk for developing pressure injuries because early signs of skin damage may not be clearly visible. Pressure injury also can occur in soft tissues from unrelieved pressure. An example, from nasal cannulas or endotracheal tubes. If the pressure is relieved within a few hours, a brief period of reactive hyperemia or redness occurs and there may be no lasting tissue damage. If the pressure continues unrelieved, the endothelial cell lining the capillaries become disrupted with platelet aggregation, forming microthrombi that block blood flow and cause anoxic necrosis of surrounding tissues. Shearing and friction are mechanical forces moving parallel to the skin, so you're dragging, and can extend to the bony skeleton, causing detachment and injury of tissues. Several scales are available for predicting pressure injury risk, such as your Braden scale, which is one of the most frequently used in the hospital system. Pressure injury staging is illustrated on the following website. One classification of stages or grades is summarized as follows. So we'll go over the different staging types just to give it a once over. Again, if you're in nursing, you're very familiar with staging. So, but for those of us who may not be in nursing, let's go over it. Non-blanchable erythema of skin that is intact, usually over a bony prominence. Darkly, darkly pigmented skin may not have visible blanching. That leads us to our partial thickness. Skin loss with exposed dermis, the erosion or intact or ruptured blistering, involving the epidermis or dermis, presenting as a shallow open ulcer, with a red-pink wound bed without slough. Deeper tissues are not visible. Then you have your full thickness, which is skin loss involving damage or necrosis of subcutaneous tissue that it may extend to but not through underlying fascia. Adipose tissue visible in the ulcer, granulation tissue, and rolled wound edges are often present. And then you have your full thickness, skin and tissue loss with exposure of muscle, bone, or supporting structures, so your tendons and joint capsules can include undermining and tunneling. And then you have your unstageable pressure injury with obscured, full thickness skin and tissue loss. Full thickness skin and tissue loss in which the extent of tissue damage within the ulcer cannot be confirmed because it is obscured by slough or eschar. And then you have your deep tissue pressure injury, or DTIs, with persistent non-blanchable skin. Your deep red, maroon, or purple discoloration of intact skin, or epidermal separation, revealing a dark wound bed or blood-filled blister caused by an underlying soft tissue damage from pressure or shear forces, or both, at the bone-muscle interface. So then you have your superficial damage, results in a layer of dead skin that appears as an abrasion, blister, erosion, or non-blanchable red darkened skin, or as a reddish blue-purple discoloration when there is deeper tissue damage. Superficial injuries are more common on the sacrum as a result of shearing or friction forces. Deep injuries develop closer to the bone as a result of tissue distortion and vascular occlusion from the pressure that is perpendicular to the tissue. Bacteria colonize the dead tissue, and infection is usually localized and self-limiting. Proteolytic enzymes from bacteria and macrophages dissolves necrotic tissue and cause a foul-smelling discharge that resembles but is not pus. The necrotic tissue initiates an inflammatory response with potential pain, fever, and leukocytosis. If the ulceration is large, toxicity and pain lead to a host of possible complications, including the loss of appetite, debility, local systemic infections, and renal insufficiency. So here you're looking at different stages of a skin ulcer. The primary goal for those at risk for pressure injury is prevention and early detection. Prevention strategies include education of caregivers, frequent skin assessment with repositioning and turning, use of prophylactic dressings to high-risk bony prominences, promotion of movement, implementation of pressure reduction, and pressure removal and elimination of excessive moisture and drainage. Adequate nutrition, oxygenation, and fluid balance must be maintained. Superficial injuries should be covered with a flat, moisture-retaining dressing that cannot wrinkle and cause increased pressure or friction. Multiple options are available. Successful healing requires continued adequate relief of pressure, debridement of dead tissue, opening of deep pockets for drainage, and repair of damaged tissue by construction of skin flaps for large, deep ulcers. Negative pressure wound healing is used in the treatment of advanced stage pressure injuries, but clinical trials are lacking. Infection requires treatment with topical and or systemic agents, but there are no clear guidelines. Pain must be controlled. Randomized controlled trials are needed to determine the best method for treating pressure injuries. So now we're talking about our keloids and our hypertrophic scars. Keloids are round, firm, elevated scars with irregular, claw-like margins that extend beyond the original site of injury. They are most common in darkly pigmented skin types and generally appear weeks to months after a stable scar has formed. Keloids have excessive deposition of fibroblast-derived extracellular matrix proteins, particularly types 1 and 3, collagen with persistent inflammation, and fibrosis. The fibroblasts have high metabolic and mitotic rates. Keloids first appear as pink or red, firm, well-defined rubbery plaques that persist for several months after trauma. Later, uncontrolled overgrowth causes extension beyond the site of the original wound, and the tumor becomes smoother, irregularly shaped, hyperpigmented, and harder, with claw-like prolongations. So here is a keloid. Hypertrophic scars are elevated, erythematous, fibrous lesions that do not expand beyond the border of injury and primarily contain type 3 collagen. Hypertrophic scars appears within 3 to 4 months and usually regress within 1 year. Both lesions are caused by abnormal wound healing with excessive fibroblast activity and collagen formation and loss of control of normal tissue repair and regeneration. Genetic susceptibility is likely. Excessive or poorly aligned tension on a wound, introduction of foreign material into the skin, infection, and certain types of trauma are provocative factors. The parts of the body at risk include the shoulders, back, chin, ears, and lower legs. Individuals 10 to 30 years of age develop lesions much more commonly than do children before puberty or older adults. Keloids are the most extreme example of cutaneous scarring and the most difficult to treat. Preventative measures, such as avoidance of unnecessary elective surgeries, recognition of familial tendency, and early detection are paramount importance. Management of keloids and hypertrophic scars includes pressure therapy, topical and intralesional corticosteroids, intralesional interferon, bleomycin and 5-fluorouracil, cryotherapy, radiotherapy, surgical laser procedures, silicone gel sheeting, onion extract containing preparations, and other therapies directed at collagen synthesis. The calcium antagonist verapamil is an emerging treatment. There remains a need for research to improve prevention strategies and treatment outcomes. Leading us to pruritus. Pruritus, or itching, is a common symptom associated with many primary skin disorders, including eczema, psoriasis, or lice infestations, or it can be a manifestation of systemic disease, or the use of opiate drugs. It may be acute or chronic, localized or generalized, and migratory. And just speaking of that gives me an itchy feeling. Multiple stimuli can produce itching, and there is interaction between itch and pain sensation. Peripheral pruritogenic mediators include histamine, neuropeptides, serotonin, prostaglandins, bradykinin, substance P, opioids, acetylcholine, interleukin 2 and 31, proteinases, and nerve growth factor. Small, unmyelinated type C nerve fibers transmit itch sensations, and specific spinal pathways carry itch sensations through the spinal cord to the brain. These nerve fibers also may interact with the dermal eosinophils, lymphocytes, and mast cells. Central nervous system mechanisms also can modulate itching, which is less perceptible when the mind is distracted by other stimuli. How the central nervous system influences the itch sensation is unclear. A neuropathic itch, an itch without a purotonic stimuli, is related to pathology along an afferent pathway. Psychogenic itch is associated with psychologic disorders. Chronic itching is an unpleasant sensation that may or may not be relieved by scratching, often done so intensely that trauma to the skin occurs, resulting in infection, skin thickening, and scarring. Both central and peripheral sensitization occurs. Management of itching is challenging and depends on the cause. The primary condition must be treated. Both topical and systemic therapies are used. So that leads us to disorders of the skin. The disruption in skin integrity may be precipitated by trauma, abnormal cellular function, infection and inflammation, and systemic diseases. Many skin disorders are benign and self-limiting, whereas others are severe and life-threatening. So, inflammatory disorders. The most common inflammatory disorders of the skin are eczema and dermatitis. Eczema and dermatitis are general terms that describe a particular type of inflammatory response in the skin and can be used interchangeably. Eczematous disorders are generally characterized by pruritus, lesions with indistinct borders, and epidermal changes. These lesions either can appear as erythema, papules, or scales, and can present in an acute, subacute, and chronic phase. Edema, serous discharge, and crusting occurs with continued irritation and scratching. In chronic eczema, the skin becomes thickened, leathery, and hyperpigmented from recurrent irritation and scratching. The location of eczema is related to the underlying cause. Eczematous inflammations need to be differentiated from other dermatoses, particularly psoriasis. Allergic Contact dermatitis. Allergic contact dermatitis is a common form of T-cell mediated or delayed hypersensitivity type 4. Again, that was discussed in chapter 9. The response is a consequence of alterations in skin barrier function with reaction to irritants, allergens, release of cytokines, chemokines, and cytotoxins from keratinocytes, dendritic cells, and natural killer cells, and neuronal responses such as pruritus. Genetic susceptibility involves several genes, and specific mutations are not clearly known. Allergens can form the sensitizing antigen. Contact with poison ivy is a common example. When the allergen comes into contact with skin, the allergen is bound to a carrier protein, forming a hapten-specific sensitizing antigen. Langerhans cells process the antigen and carry it to T cells in the draining lymph nodes. T cells then become sensitized to the antigen, releasing cytokines and chemokines, leading to leukocyte infiltration and antigen-specific inflammation. Latex allergy can be either a type 4 hypersensitivity reaction to chemicals used on latex rubber processing, or a type 1 immediate hypersensitivity reaction with immunoglobulin E antibodies formed in response to latex rubber proteins. So here we're taking a look at poison ivy. In delayed hypersensitivity, several hours pass before an immunologic response is apparent. The T cells play an important role because they differentiate and secrete lymphokines that affect skin macrophages, movement, and aggregation, coagulation, and other inflammatory responses. Sensitization usually develops with first exposure to the antigen, and symptoms of dermatitis occurs with re-exposure. The manifestations of allergic contact dermatitis include erythema and swelling with pruritic vesicular lesions in the areas of allergen contact. The pattern of distribution provides clues to the source of antigen. Chronic atopic dermatitis results in lichenification, fissuring, thickening, and scaling of the skin. Patch tests with specific antigens assist with diagnosis and differentiation from other dermatoses. Removal of the allergen is necessary for resolution of the inflammatory response and tissue repair. Treatment may require topical and systemic steroids. Which leads us to our irritant contact dermatitis. Irritant contact dermatitis is a nonspecific inflammatory dermatitis caused by activation of the innate immune system by pro-inflammatory properties of chemicals. The intensity of the inflammation is related to the concentration of the irritant, exposure time, disruption of the skin barrier, and age. Irritation can occur from almost anything, especially if the epidermal barrier is compromised in any way. The skin lesions are similar in appearance to allergic contact dermatitis. Removing the source of irritation and using topical agents and non-irritating soaps constitute effective treatments. So here you have your substances known to cause contact dermatitis. Again, it's a good spot to just kind of review to give you a general idea of what may cause dermatitis. So it's not a bad spot to hit pause every once in a while, just to at least give it a once over. Atopic dermatitis. Atopic dermatitis, also known as atopic eczema, is more common in infancy and childhood. However, some individuals are affected throughout lifetime. Your stasis dermatitis. Stasis dermatitis usually occurs on the legs as a result of venous stasis and edema. The disorder is associated with varicositis. phlebitis, and vascular trauma. Pooling of venous blood traps leukocytes that may release proteolytic enzymes. Increased venous pressure widens interendothelial pores with deposition of red blood cells, fibrin, and other macromolecules, making them unavailable for repair and promoting inflammation. Edema evolves to erythema and pruritus with progression to scaling, petechiae, and hyperpigmentation. Progressive lesions become ulcerated, particularly around the ankles and the tibia. So here you're looking at a stasis ulcer. Treatment includes elevating the legs as often as possible, refraining from wearing tight clothes around the legs, compression stockings, and avoiding standing for long periods. Defined infections are treated with antibiotics. Chronic lesions with ulcerations are treated with moist dressings. External compressions or dressings, and vein ablation surgeries. That leads us to seborrheic dermatitis. Seborrheic dermatitis is a common chronic inflammation of the skin involving the scalp, eyebrows, eyelids, ear canals, nasolabial folds, axillae, chest, and back. In infants, it is known as cradle cap. Proposed theories include genetic predisposition, phospholipases from Malassezia yeast, immunosuppression, and epidermal hyperproliferation. Malassezia infection causes inflammation with stratum corneum hyperproliferation and incomplete corneocyte differentiation. Alteration in the stratum corneum barrier allows water to more readily leave the skin. Lesions develop from infancy to old age, with periods of remission and exacerbation. The lesions appear as greasy, scaly, white, or yellowish inflammatory plaques in sebaceous areas and mild pruritus. Topical agents are first-line therapy and include antifungal agents, keratolytics, and anti-inflammatory agents. So here you're taking a look at seborrheic dermatitis of the nose. Your papulosquamous disorders. So that includes your psoriasis, pityriasis rosacea, and lichen planus are inflammatory disorders characterized by papules, scales, plaques, and erythema. Collectively, they're described as papulosquamous disorders. So, psoriasis. Psoriasis is a chronic, relapsing, proliferative inflammatory disorder that involves the skin, scalp, and nails, and can occur at any age. Psoriasis affects about 1 to about 11% of the world population and is more common in countries north of the equator. The onset is generally established by 40 years of age. A family history of psoriasis is estimated at about 60 to 90% of cases. The genetic mechanism are complex and involve skin barrier function and innate and adaptive immunity. The onset of psoriasis later in life is less familial and more secondary to comorbidities such as obesity, smoking, hypertension, and diabetes. Triggers of psoriasis include physical injury, infections, and medications. The inflammatory cascade of psoriasis involves the complex interactions between macrophages, fibroblasts, dendritic cells, natural killer cells, T helper cells, and regulatory T cells. Psoriasis is a T helper cell-mediated autoimmune disease. The interleukin 23 T helper or 17 cell axis plays an important role in the pathogenesis of psoriasis. Inflammatory cytokines involved include tumor necrosing factor alpha, interferon gamma, and numerous interleukins derived from activated T cells, B cells, dendritic cells, and macrophages. These inflammatory markers are the target for several therapeutic drugs known as the biologics. Both the dermis and epidermis are thickened because of keratinocyte hyperproliferation, altered keratinocyte differentiation, and expanded dermal vasculature. The turnover time for shedding the epidermis is decreased to 3 to 4 days from the normal 26 to 30 days. With many more germinative cells and an increase in transit time of the cells through the dermis, cell maturation and keratinization are bypassed, and the epidermis thickens and plaques form. The loosely cohesive keratin gives the lesion a silvery, scaly appearance. Capillary dilation and increased vascularization occurs from release of angiogenic factors, such as vascular endothelial growth factor, and accommodate the increased cell metabolism and cause erythema. The disease can be mild, moderate, or severe depending on the size, distribution, inflammation, and type of lesion. Psoriasis is marked by remission and exacerbations. The type of psoriasis include plaque, inverse, guttate, pustular, and erythrodermic. Plaque psoriasis is the most common and affects 80 to 90% of individuals with psoriasis. Early onset psoriasis is an inflammatory lesion with epidermal hyperproliferation, the presence of activated T lymphocytes, and numerous cytokines, including interleukin 1, 6, 17, 22, tumor necrosing factor alpha, and interferon gamma. The typical lesion of plaque psoriasis is a well-demarcated, thick, silvery, scaly, erythematous plaque surrounded by normal skin that can appear anywhere on the body. Small erythematous papules enlarge and coalesce into larger inflammatory lesions, more commonly on the face, scalp, trunk, elbows, and knees, and at sites of trauma. Inverse psoriasis is rare and involves lesions that develop in skin folds, often misdiagnosed as a fungal infection. They are large, smooth, dry, and deep red. So here we're taking a look at psoriasis. In guttate psoriasis, small papules, anywhere from 1 to 10 millimeters, appear suddenly on the trunk and extremities. The lesions may appear a few weeks after a streptococcal respiratory tract infection and are more common in children. Guttate psoriasis may resolve spontaneously in weeks or months. Pustular psoriasis appears as blisters of the non-infectious pus that develop over areas of plaque psoriasis and represents a flare of disease with involvement of interleukin 1 alpha, 1 beta, 36, tumor necrosing factor alpha, and interferon alpha. Erythrodermic psoriasis is characterized by widespread red, scaling lesions that cover a large body surface area and is often accompanied by itching or pain associated with constitutional symptoms and skin infections. So your fever, your chills, your fatigue. So here you're taking a look at your guttate psoriasis after a streptococcal infection. Psoriatic arthritis is associated with a pro-inflammatory cytokines that cause psoriatic skin lesions, particularly the interleukin 23, Th or T helper 17 axis, and tumor necrosing factor alpha. There are several phenotypes, including asymmetric arthritis of major joints, enthesitis, dactylitis, and nail disease. Psoriatic arthritis mutilans involves pronounced bone destruction, and the greater the risk of cardiovascular disease and PSA. So your psoriatic arthritis. Psoriatic nail disease can occur in all psoriasis subtypes, with pitting, ankylosing, subungual hyperkeratosis, and nail plate dystrophy. Psoriasis also is a risk factor for a number of comorbidities, including uveitis, inflammatory bowel disease, metabolic syndrome, including hypertension, insulin resistance, dyslipidemias, and abdominal obesity, depression and anxiety, chronic obstructive pulmonary disease, and increased risk for atherosclerosis and cardiovascular disease that is independent of traditional risk factors for these diseases. Treatment is individualized and related to maintaining skin moisture, reducing epidermal cell turnover and pruritus, and promoting immunomodulation. Mild lesions are usually treated with emollients, keratolytic agents, corticosteroids, and vitamin D analogs. Narrowband phototherapy, cyclosporin, methotrexate, acitretin, and biologics such as tumor necrosis factor alpha antagonists and drugs that specifically target the interleukin 23 and 17 axis are reserved for moderate to severe forms of disease. New drugs are under investigation for safety, efficacy, and cost. That leads us to pityriasis rosea. Pityriasis rosea is a self-limiting inflammatory disorder that occurs more often in children and young adults. The cause is thought to be a herpes-like virus. Pityriasis rosea begins as a single lesion known as a herald patch that is circular, demarcated, and salmon pink, is approximately 3 to 10 centimeters in diameter, and is usually located on the trunk. Early lesions are macular and papular, followed by lesions that develop within 14 to 21 days and extend over the trunk and upper part of the extremities, and rarely on the face. The small erythematous, rose-colored papules expand into characteristic oval lesions that are bilateral and symmetrically distributed. There may be few or hundreds of lesions. The pattern of distribution follows the skin lines around the trunk and resembles a drooping pine tree. Scales slough from the margin of the lesion, forming a collarette pattern. Itching is the most common symptom. Occasional headache, fatigue, or sore throat may precede the development of the lesion. So here you're taking a look at pityriasis. The diagnosis of pityriasis rosea follows the clinical appearance of the lesion. Secondary syphilis, psoriasis, drug eruption, nummular eczema, and seborrheic dermatitis are among the differential diagnosis considerations. The disorder is usually self-limiting and resolves in a few months with symptomatic treatment for pruritus or cosmetic concerns. UV light, antihistamines, or topical corticosteroids may be used to control itching. Erythromycin and acyclovir also may be used for treatment. When diagnosed during pregnancy, there is increased risk for miscarriage or premature delivery from viral infection, and antiviral therapy should be considered. Lichen planus, or LP. Lichen planus is a benign autoimmune inflammatory disorder of the skin and mucous membranes with multiple clinical variations. The age of onset is usually between 30 and 70 years. The stimulating antigen is unknown, but T cells, adhesion molecules, inflammatory cytokines, perforin, and antigen-presenting cells are involved. The, the infiltrate of T cells mediates immunoreactivity against basal layer keratinocytes, which have altered surface antigens and adhesion molecules. Lichen planus is also linked to hepatitis C virus. The disorder begins with non-scaling, purple-colored, flat-topped, polygonal, pruritic papules, 2 to 4 millimeters in size, usually located on the wrists, ankles, lower legs, and genitalia. New lesions are pale, pink, and evolve into dark violet. Persistent lesions may be thickened and red, forming hypertrophic lichen planus. Oral lesions appear as lacy white rings that must be differentiated from leukoplakia or oral candiditis, and they may be precancerous lesions in about 1% of cases. Fine white lines, known as the Wickham stria, can be seen throughout the oral lesions on magnification. These lesions also can develop on the penis and vulvovaginal area. Oral lesions do not commonly ulcerate, but, if present, are painful and require treatment. Chronic ulcerated lesions become malignant in 1% of individuals with the disease. Thinning and splitting of nails are common, and all or part of the nail may be shed. So here you're taking a look at the hypertrophic lichen planus on an arm. Pruritus is the most distressing symptom. The lesions are self-limiting and may last for months or years, with an average duration of about 6 to 18 months. Post-inflammatory hyperpigmentation is a common consequence of the lesion. About 20% of individuals have a recurrence. Diagnosis is made by the clinical appearance and histopathology of the lesion. Treatment is individualized and includes topical, intralesional, or systemic corticosteroids, and systemic acitretin and narrowband ultraviolet light therapy. Antihistamines are given for itching, and short-term use of topical or systemic glucocorticoids may control inflammation. Mucous membrane lesions are treated with potent topical steroids, topical retinoids or immunomodulators, and systemic glucocorticoids. Acne vulgaris. Acne vulgaris is an inflammatory disorder of the pilosebaceous follicle. It occurs most commonly during adolescence. Details of the disorder are more discussed in chapter 48. Your hidradenitis suppurativa, or inverse acne. I'm going to call it inverse acne, is a chronic, inflammatory, recurring scarring disease of the pilosebaceous follicular ducts, involving areas of skin where there are folds, hair follicles, and apocrine glands. The incidence is unknown, but is estimated in 1 to 4% of the population and is more common in females. The pathogenesis of the disease is complex and includes a combination of genetic, hormonal, immune, and environmental factors. Aggravating factors include smoking, tight clothing, heat and perspiration, obesity, and stress. An aberrant response to commensal follicular bacteria results in inflammatory cytokine production, with follicular hyperkeratosis and occlusion of the pilosebaceous unit, causing perifolliculitis, abscess formation, sinus tracts, and scarring. The sweat glands are not primarily involved. The lesion presents as deep, firm, painful, sebaceous nodules that track and rupture horizontally under the skin. They are differentiated from boils because boils extend vertically and discharge onto the skin. So here you're taking a look at the hidradenitis suppurativa. Diagnosis can be difficult, delaying effective treatment. Treatment can include administering systemic medications, performing incision and drainage of nodules, obtaining a culture of the exudate, and giving antibiotics. With concern about the presence of a methicillin-resistant Staphylococcus aureus, topical or intralesional corticosteroids and retinoids. Biologics are options when other treatment fails. Lesions often require surgical excision and skin grafting. Complete spontaneous resolution is rare, and there is risk for squamous cell carcinoma. Deterrence includes avoiding heat, and perspiration. Losing weight if obese, wearing loose clothing, refraining from shaving affected areas, stopping smoking, and using zinc gluconate supplements to reduce inflammation. The disease can recur for years with negative effects on quality of life. Clinical trials are needed to identify the best treatment options. That brings us to acne rosacea. Acne rosacea is a chronic inflammatory skin disease with varied presentations and extent of involvement that develops primarily in middle-aged adults. There are four subtypes of lesions that can occur singly or in combination: erythema total angiectatic, papulopustular, phymatous, and ocular. The cause is unknown. There is a familial tendency, and several genes have been identified. Neurovascular dysregulation, infection, and factors that trigger altered innate and adaptive immune response are involved. The most common lesions are erythema and edema, papules, pustules, telangiectasia, occurring most commonly on the forehead, nose, cheeks, and chin. Neurovascular dysregulation is associated with flushing, a burning sensation, and vasodilation. Alterations in epidermal barrier function and activation of T and B cells promote inflammation and the production of your angiogenic factors and fibrogenic cytokines, promoting formation of telangiectasia, fibrosis, and cutaneous thickening. Sebaceous hypertrophy, fibrosis, and telangiectasia may be severe enough to produce an irreversible bulbous appearance of the nose known as rhinophyma. Facial application of fluorinated topical steroids may increase the severity of telangiectasias. Disorders of the eyes often accompany rosacea, particularly conjunctivitis, and, more rarely, keratitis, which can result in visual impairments. Photoprotection, such as sunscreens or protective clothing, is essential, along with avoidance of other triggers. Both topical and oral drugs may be effective, as well as the treatment using pulsed lasers. Surgical excision of the excessive tissues may be required for rhinophyma. Your lupus erythematosus. Lupus erythematosus is a systemic inflammatory autoimmune disease with cutaneous manifestations. Again, look at Chapter 9. Cutaneous lupus erythematosus is limited to the skin and often progresses to systemic lupus erythematosus. So here we're taking a look at lupus. The cutaneous lupus erythematosus usually occurs in genetically susceptible adults, particularly women in their late 30s and early 40s, but people of any age can be affected. Environmental triggers can initiate the inflammatory response, including infections, hormones, UV radiation, and exposure to drugs and chemicals. There are three subtypes of CLE, or the cutaneous lupus, with specific manifestations of the disease: acute, subacute, and chronic. The lesions may be single or multiple, and of various sizes. Often, the lesions are located on the light-exposed areas of the skin, and photosensitivity is common. The face is the most common site of a lesion involvement. The characteristic manifestations of the different categories of CLE are summarized in the following table. So here is a good spot to hit pause to read over the categories and manifestations of cutaneous lupus erythematosus, because there are acute, localized, and generalized, subacute, and chronic. The cause is unknown, but thought to be related to genetic and environmental factors, and an altered immune response to an unknown antigen or response to UVB wavelengths, with development of self-reactive T and B cells, decreased number of regulatory T cells, and increased levels of pro-inflammatory cytokines. Autoantibodies and immune complexes cause tissue damage and inflammation. Diagnosis of CLE is made from presenting symptoms, biopsy of skin lesions with direct immunofluorescence, as well as histologic results. Skin biopsy with immunofluorescent observation reveals lumpy deposits of immunoglobulins, including IgM, IgG, and C3. The revised cutaneous lupus erythematosus disease area and severity indexes can be used to assess disease severity. Individuals with CLE must use sunscreen and sun protection because direct sun exposure initiates or exacerbates lesions. Treatment options include topical steroids, calcineurin inhibitors, and antimalarial drugs. These medications must be used with caution to prevent serious side effects. Immunotherapy is being evaluated for treatment of CLE. Vesiculobullous Disorders. Vesiculobullous skin disease share a common characteristic of vesicles or blisters formation. Two such diseases are the pemphigus and erythema multiforme. So we'll jump into pemphigus first. Pemphigus, meaning to blister or bubble, is a group of rare autoimmune blistering diseases of the skin and oral mucous membranes. It is caused when circulating immunoglobulin G, autoantibodies, and C3 complement bind to the desmoglein adhesion molecules, resulting in the destruction of cell-to-cell adhesion at the desmosomal cell junction in the suprabasal layer of the epidermis, with fluid accumulation and the resulting symptoms of blister formation. Pemphigus can occur in all age groups, but is more prevalent between 40 and 50 years of age. There is a genetic predisposition as well as an environmental influence, physical effects, and endogenous. Pemphigus presents in varying forms, often with painful, superficial erosions, prone to infection. So, your pemphigus vulgaris is the most common form. Oral lesions precede the onset of skin blistering, which is more prominent on the face, scalp, and axilla. The blisters rupture easily because of the thin, fragile overlying portion of the epidermis, resulting in painful erosions. Pemphigus vigilans is a rare variant of Pemphigus vulgaris with large blisters that progress to hypertrophic granulomas with tissue erosion and pustules. They usually occur in skin tissue folds. Pemphigus violaceus is a milder form of the disease and involves acantholysis at the subcorneal level with blistering, erosions, scaling, crusting, and erythema, usually of the face and chest. Oral mucous membranes are rarely involved. Pemphigus erythematosus is a subset of Pemphigus foliaceus, often associated with systemic lupus erythematosus with positive anti-nuclear antibodies. The lesions are generally less widely distributed. Paraneoplastic pemphigus, is the most severe form of pemphigus and is associated with a lymphoproliferative neoplasm. Internal organs, including the lungs, thyroid, kidney, smooth muscle, and gastrointestinal tract are involved, leading to the term paraneoplastic autoimmune multi-organ syndrome. In contrast to pemphigus vulgaris, the lesions develop from inflammatory papules or macules rather than normal skin. IgA pemphigus is the most benign form of pemphigus characterized by tissue-bound and circulating IgA antibodies targeting desmosomal or non-desmosomal cell surface components in the basement membrane of the epidermis. Acantholysis is not as severe as that in pemphigus vulgaris, but there is still blistering formation. Pemphigus herpetiformis is a very rare form of pemphigus that resembles dermatitis herpetiformis, or blistering lesion that have appearances of herpes lesions, but with immunologic and histologic findings consisting those of pemphigus and not of herpes. The diagnosis of pemphigus is made from the clinical manifestation and histologic findings of autoantibodies in the epidermis or mucosal epithelium. Immunofluorescence demonstrates the presence of antibodies at the site of blisters formation. The clinical course of the disease may range from rapidly fatal to relatively benign. The primary treatment for pemphigus is systemic corticosteroids in combination with adjuvant immunosuppressants and, in difficult cases, adjuvant protein A immunoabsorption, intravenous immunoglobulins, plasmapheresis, and anti-CD20 monoclonal antibody therapy. Newer methods of treatment and clearer understanding of the pathogenesis have improved the prognosis and decreased mortality. Bullous pemphigoid. Bullous pemphigoid is a more benign autoimmune disease than pemphigus vulgaris, with blistering of the basement membrane of the skin, not the cell junction. Autoantibodies, your IgG and IgE, to transmembrane collagen proteins, your collagen 17 and BP180, have been found. There are numerous triggers, including drugs and skin trauma. The autoantibodies activate complement with inflammatory infiltration of neutrophils, eosinophils, and lymphocytes. Loss of dermal epidermal adhesion is caused by inflammatory cytokines. The lesions of pemphigoid begin with localized erythema or as pruritic plaques that extend and become edematous. The plaques turn reddish-purple by 2 to 3 weeks, with vesicles and bullae emerging on the surface. Oral lesions can occur. The bullae do not extend with pressure. The blisters rupture within 1 week and heal rapidly. BP occurs more commonly after 60 years of age. Diagnostic criteria include age more than 70 years of age, absence of atrophic scars, mucosal involvement, and bullous lesions of the head and neck, and results of skin biopsy and immunofluorescent examination. The presence of subepidermal blistering and eosinophils distinguishes pemphigoid from pemphigus. Treatment usually includes antihistamines for itching and topical or systemic corticosteroids. Adjuvant immunosuppressive drugs may be prescribed. Relapse may occur with discontinuation of treatment. So here is a picture of that bullous pemphigoid. Erythema multiforme. Erythema multiforme minor is a syndrome characterized by inflammation of the skin with minimal or no mucous membrane involvement and no systemic symptoms. Erythema multiforme major has moderate to severe mucosal involvement and some systemic symptoms. Your erythema multiforme, or EM, is often associated with a T-cell mediated type 4 hypersensitivity reaction to a microorganism, particularly a viral infection, your herpes simplex and Epstein-Barr virus, or, more rarely, histoplasmosis and mycoplasma pneumoniae that target small blood vessels in the skin or mucosa. It is rarely related to drug reactions. The incidence of EM is not well defined and can occur at any age, but is more common in children and young adults. Immune complex formation and deposition of complement, IgM, and fibrinogen around the superficial dermal blood vessels, basement, basement membrane, and keratinocytes are common histology findings. Edema develops in the superficial dermis, leading to the formation of vesicles and bullae. Both EM minor and major have characteristic bull's eye or target lesions that occur on the skin surface with central dusky regions surrounded by concentric rings or alternating edema and inflammation commonly over the extensor surface of the limbs. The lesions usually occur suddenly in groups over 2 to 3 weeks. Urticarial plaques, 1 to 2 centimeters in diameter, can develop without the target lesion. EM major, or vesiculobullous form, includes mucous membrane lesions and erythematous plaques. Single or multiple vesicles, or bullae, may arise on a part of the plaque, accompanied by pruritus and burning. EM is self-limiting. Lesions heal within 3 to 4 weeks and rarely recur. For extensive involvement, systemic steroids may be indicated, along with supportive care for mucositis and skin erosions, or daily viral suppression for recurrent infectious etiology. So here we see the erythema multiforme caused by doxepin. Stevens-Johnson syndrome and toxic epidermal necrosis, or necrolysis rather. Stevens-Johnson syndrome and toxic epidermal necrolysis are the same disease with a continuum of symptoms based on clinical presentation and symptom severity. They are rare, distinct from EM, and usually associated with severe cutaneous drug reactions and extensive keratinocyte cell death characterized by extensive bullous epidermal detachment, mucositis, and other organ involvement. Stevens-Johnson syndrome involves less than 10% of the BSA and is milder than toxic epidermal necrolysis. Toxic epidermal necrolysis involves more than 30% of BSA. Both, or Stevens-Johnson syndrome and toxic epidermal necrolysis, overlap in its BSA involvement between 10 and 30%. Lesions appear 3 to 10 days after drug introduction. Your cytotoxic T lymphocytes and human leukocyte antigen restricted fashion mediate the immune mechanism related to drug reactions. Genetic markers have been identified for these reactions and are used to guide the prevention and therapy. Prodromal symptoms of TEN include fever, headache, malaise, sore throat, and cough in approximately 1/3 of cases. Blisters and bullae form and large areas of necrotic epidermis may be shed, leaving open weeping, painful areas of underlying skin. Mucosal involvement may be extensive and involve the mouth, air passages, esophagus, urethra, and conjunctiva. Blindness can result from corneal ulcerations. Difficulty with eating, breathing, and urinating may develop with severe manifestations. The SJS-TEN overlap also can affect the gastrointestinal, genitourinary, and respiratory systems. The mortality rate for these conditions is as high as 40% and usually related to infection or multiple organ failure, or both. Medication history preceding the development of lesions and a skin biopsy are required to establish the diagnosis and differentiate the reaction from staphylococcal scalding skin syndrome. A severity of illness score for toxic epidermal necrolysis syndrome guides treatment and predicts mortality. Any ongoing drug therapy should be withdrawn or re-evaluated and underlying infections treated. Treatment is individualized according to severity and, in severe cases, requires the care of a burn unit. Fluid and electrolyte balance should be monitored in severe forms of these cases. the mucous membranes must be carefully managed with a bland diet. Warm saline eye washes, topical anesthetics, or corticosteroids to maintain comfort and prevent infection. Use of, use of systemic steroids is controversial. Cutaneous blisters can be treated with wet compresses of Burlow solution. Ophthalmic, kidney, and lung involvement requires special care. Resolution occurs in 8 to 10 days, usually without scarring. Mucosal lesions may take 6 weeks to heal. So, infections. Cutaneous infections are common forms of skin disease. They generally remain localized. However, serious, potentially life-threatening complications can develop with systemic involvement. The types of skin infection include bacterial, viral, and fungal. The commensal flora of the skin often provides protection against pathogens that cause skin infections, including Staphylococcus and Streptococcus. Bacterial infections. Most bacterial infections of the skin are caused by local invasion of pathogens. Coagulase positive Staphylococcus aureus and, less often, beta hemolytic streptococci are the common causative microorganisms. Community acquired excuse me. Community acquired methicillin resistant Staphylococcus aureus is also a cause of a serious skin infection, particularly skin abscesses. So here is a box on community-acquired methicillin-resistant Staphylococcus aureus. Here is a great spot to hit pause if you wish to read about it. I'll leave both sides open so you can read the whole entire thing. But again, good spots to hit pause just to make yourself a little smarter. Folliculitis. Folliculitis is an inflammation of the hair follicle and can be infectious rather, caused by bacteria, viruses, fungi, or a non-infectious, caused by trauma or plugging of a follicle. S. aureus is a common causative microorganism. The infection develops from proliferation of the microorganism around the opening of the follicle and then spreads into the follicle. Inflammation is caused by the release of chemotactic factors and enzymes from the bacteria. The lesion appears as pustules and papules with a surrounding area of erythema. The pus is sterile and non-infectious folliculitis. Lesions are most prominent on the scalp and extremities and rarely cause systemic symptoms. Prolonged skin moisture, occlusive clothing, topical agents, skin trauma, and poor hygiene are associated contributing factors to the development of folliculitis. Cleaning with soap and water and topical application of antibiotics are effective forms of treatment. Furuncles and carbuncles. Furuncles or boils are inflammations of the hair follicles. They may develop from a preceding folliculitis that spreads through the follicular wall into the surrounding dermis. The invading microorganism is usually S. aureus, including C.A. MRSA. The infecting strain may spread to the skin from the anterior nares. Any skin area with hair can be infected, and one or more lesions may be present. The precipitating events are similar to those of folliculitis. The initial lesion is a deep, firm, red, painful nodule 1 to 5 centimeters in diameter. Within a few days, the initial erythematous nodule changes to a large, fluctuant and tender cystic nodule that may be accompanied by cellulitis. No systemic symptoms are present, and lesions may drain large amounts of pus and necrotic tissue. So here you're taking a look at the furuncle on a forearm. A carbuncle is a collection of infected hair follicles and usually occur on the back of the neck, upper back, and lateral thigh. The lesion begins in the subcutaneous tissue and lower dermis as a firm mass that evolves into the erythematous, painful, swollen mass that drains through many openings. Abscesses may develop. Chills, fever, and malaise are systemic symptoms that can occur during the early stages of lesion development. Furuncles and carbuncles are treated with warm compresses to provide comfort and promote localization and spontaneous drainage. Abscess formation requires incision and drainage, and recurrent infections, extensive lesions, or those associated with cellulitis or systemic symptoms are treated with systemic antibiotics. Cellulitis. Cellulitis is an infection of the dermis and subcutaneous tissue, usually caused by Staphylococcus, ca MRSA, or a group B streptococci. Cellulitis can occur as an extension of the skin wound, of an ulcer, or from furuncles or carbuncles. It can be associated with chronic venous insufficiency and stasis dermatitis. Risk factors include diabetes mellitus, edema, peripheral vascular disease, tinea pedis, insect bites, and immune suppression. The infected area is erythematous, warm, swollen, and painful, and can extend to lymph nodes and the blood. Initial systemic treatment with antibiotics should cover both staphylococci and streptococci. The burrow soaks can be used to relieve pain. Corticosteroids are used for adjuvant therapy. Cellulitis must be differentiated from necrotizing fasciitis. Necrotizing fasciitis, also known as flesh-eating disease, is a rare, rapidly spreading infection. It is commonly caused by Streptococcus pyogenes, which resists phagocytosis and releases toxins. Infection starts in the fascia, muscles, and subcutaneous fat, with subsequent necrosis of the overlying skin and can progress to sepsis and death without early diagnosis and treatment. Risk factors include older age, chronic disease such as cirrhosis, diabetes, or chronic renal failure, immunosuppression, and malnutrition. Treatment requires antibiotics and often surgical debridement. Erysipelas. Erysipelas is an acute superficial infection of the upper dermis, often caused by Streptococcus pyogenes, beta hemolytic streptococci, and S. aureus. The face, ears, and lower legs are common sites of involvement, and the site of initial infection may not be identified. Chills, fever, and malaise precede the onset of the lesion by 4 hours to 20 days. The initial lesion appears as firm red spots that enlarge and coalesce to form a clearly circumscribed advancing edge. Bright red, hot lesions with a raised border. Vesicles may appear over the lesion and at the border, producing a bullous form of the disease. Pruritus, burning, and tenderness accompany the development of the lesion. Cold compresses provide symptomatic relief, and systemic antibiotics are required to arrest the infection. Impetigo. Impetigo is a superficial infection of the skin caused by coagulase positive S. aureus or alpha hemolytic streptococci. The disease does occur in adults but is more common in children. Again, see Chapter 48. Lyme's disease. Lyme's disease is a multisystem inflammatory disease caused by the spirochete Borrelia burgdorferi, transmitted by tick bites, and is the most frequently reported vector-borne illness. The highest incidence is among children. The microorganism is difficult to culture, escapes immune defenses through antigenic variation, blocks complement-mediated killing, impedes release of antimicrobial peptides, leukocyte chemotaxis, and antimicrobial killing, and hides in tissue. It spreads to other tissue by entering capillary beds. Symptoms of the disease occur in 3 stages, although 50% of the infected individuals are symptom-free. Localized infections occur soon after the bite, within 3 to 32 days, with erythema migrans and the bullseye rash, commonly appearing at the site of the tick attachment, with or without fever, fatigue, malaise, myalgia, and arthralgias. Erythema migrans is a T cell mediated response. Within days to weeks after the onset of illness, there is disseminated infection, with secondary erythema migrans, usually with myalgias, arthralgias, and more rarely meningitis, neuritis, or carditis. Post-Lyme disease syndrome, or chronic Lyme disease, can continue for years with arthritis, encephalopathy, polyneuropathy, or heart failure. The diagnosis of Lyme's disease is based on the clinical presentation and history of tick bite, if known. Serologic tests may be used to confirm the diagnosis, although there is a delay in antibody response, and the test may be negative during the first 3 weeks after infection. Antibiotics, amoxicillin, are used for treatment, with longer treatment required for arthritis or active neurologic disease. Reinfection can occur. There currently is not a vaccine for Lyme's disease. Your viral infections. Your herpes simplex virus. Skin infections with herpes simplex virus, or HSV, are commonly caused by two types, HSV1 and 2. Either type can occur in different parts of the body, including the oral and genital locations. Their differences are distinguished by laboratory tests. HSV1, transmitted by contact with infected saliva, is generally associated with oral infections, cold sores, or fever blisters, or infection of the cornea, herpes keratitis, mouth, gingivitis, and oralabia, lips, labialis. But it also can cause genital herpes, with initial primary infection. The virus infects epithelial cells, embeds in sensory nerve endings, and moves by retrograde axonal transport to the dorsal root ganglion, where the virus develops a lifelong latency. The incubation period ranges from 2 to 14 days. During the secondary phase, the lesion occurs at the same site from reactivation of the virus. The virus travels down the peripheral nerve to the site of the original infection, where it is shed. Exposure to ultraviolet light, skin irritation, fever, fatigue, menses, or stress may cause reactivation. The lesions for HSV1 appear as a rash or clusters of inflamed and painful vesicles. Increased sensitivity, paresthesias, and mild burning often occur before onset of lesions. The vesicles rupture, forming a crust. Lesions may last from 2 to 6 weeks. Treatment is symptomatic and includes topical antiviral agents. Lesions usually resolve within 2 weeks. Oral antivirals may be indicated at the time of acute infection or through daily suppressive dosing to prevent acute infections. So here's a picture of the herpes simplex. Genital infections are more commonly caused by HSV2. The virus is spread by skin-to-skin mucous membrane contact during viral shedding. Risk of infection is high in immunosuppressed persons or in persons who have sexual contact with infected individuals, and increased risk for human immunodeficiency virus or HIV infection. Vertical transmission from mother to neonate is associated with significant neonatal neurologic morbidity and mortality. The primary infection is asymptomatic. With recurrent exposure, the lesions begin as small vesicles that progress to ulceration within 3 to 4 days with pain, itching, and weeping. Treatment is symptomatic and includes topical or oral antiviral agents or daily antiviral suppression for recurrent episodes. Progress is being made with prophylactic vaccines. That leads us now to the similar herpes zoster and varicella. Herpes zoster and herpes varicella, as your shingles and chickenpox, again, look at them more specifically in chapter 48, are caused by the same herpes virus, the varicella zoster virus. Your varicella zoster virus occurs as a primary infection, followed years later by activation of the virus when the immunity declines to cause herpes zoster or shingles. During this time, the virus remains latent in the trigeminal and dorsal root ganglia. Herpes zoster has initial symptoms of pain and paresthesia localized to the affected dermatome, followed by the vesicular eruptions along the facial, cervical, and thoracic lumbar dermatome. Lesions do not usually cross the midline. Local symptoms are alleviated with compresses, calamine lotion, or baking soda. Persistent pain may last for weeks or months and is a debilitating complication, particularly in older adults, and requires treatment. About 15 to 20% of individuals experience post-herpetic neuralgias, particularly those older than the age of 60. There is no cure for herpes zoster. Antiviral drugs are useful if used within the first 72 hours. Tricyclic antidepressants and analgesics are helpful treatments. The varicella vaccine is safe and effective in both children and adults, particularly those older than the age of 60. In children, the vaccine is given to prevent chickenpox, and in adults, particularly in the elderly, the vaccine is given to prevent herpes zoster. So here we're taking a look at herpes zoster. Talking about warts. Warts, or verruculae, are benign lesions of the skin caused by the many different types of human papillomavirus that infect the stratified epithelium of the skin and mucous membranes. Specific viruses are associated with specific kinds of locations of lesions. The lesions can occur anywhere, are flat, round, or fusiform, and elevated with rough grayish surface. Warts are transmitted by touch. Common warts occur most often in children and are usually on the fingers. Plantar warts are usually located at the pressure points on the bottom of the feet. So here you're taking a look at plantar warts. The diagnosis of warts is by visualization. Treatment considers age of the individual and size and location of the lesion. Warts can be removed by freezing with liquid nitrogen, electrocauterization, vaporization with lasers, application of keratolytic, or application of irritants and corrosives, such as salicylic acid, formaldehyde, interferons, and podophyllum. Recalcitrant warts may benefit from application of topicals, such as imiquimod 5% cream, or 5-fluorouracil by intralesional injections of bleomycin or candida, or by more aggressive surgical procedures. Many warts resolve spontaneously, but often can reoccur. Condylomata acuminata, or venereal warts, are highly contagious and sexually transmitted. The cauliflower-like lesion occurs in moist areas along the glands of the penis, vulva, and anus. See chapter 27. Oncogenic HPV, types 16 and 18, is a primary cause of cervical and other types of cancers. So that was viral infections, but now we're leading into fungal infections. The fungi causing superficial skin infections are called dermatophytes, and they thrive on keratin. Fungal disorders are known as mycosis when caused by dermatophytes. The mycosis are termed tinea. Tinea infections. Tinea infections are classified according to their location on the body. Tinea pedis is shown in the following figure, so we're looking at that, and the most common sites are summarized in the following table. So let's take a look at that table and hit pause. So common sites: Tinea carpatus, the scalp; Tinea corposus; Tinea cruris; Tinea pedis; Tinea manus; Tinea unguiunum or Onychomycosis. Again, if I ever go too fast, pause, pause, pause. Tinea is diagnosed by culture, microscopic examination of the skin, scrapings prepared with potassium hydroxide wet mount, or observation of the skin with a UV light. Cultures establish the particular type of fungus and are necessary for hair and nail infections. Fungi have characteristic spores and filaments, known as hyphae, that are more prominent when prepared in potassium hydroxide. The spores fluoresce blue-green when exposed to UV light. Treatment is related to the type of fungi and include both topical and systemic antifungal medication. Candidiasis. Candidiasis is caused by a yeast-like fungus, Candida albicans, and normally can be found on mucous membranes on the skin, in the gastrointestinal tract, and in the vagina. Candida albicans can, under certain circumstances, change from commensal microorganism to pathogen, particularly in the critical ill and those who are immunosuppressed. Factors that predispose to infection include a local environment of moisture, warmth, maceration, or occlusion. The systemic administration of antibiotics, pregnancy, diabetes, Cushing disease, debilitated states, infants younger than 6 months as a result of a decreased immune reactivity, immunosuppression, and certain neoplastic diseases of the blood and monocyte macrophage system. The commensal bacteria on the skin, mainly cocci, inhibit proliferation of C. albicans. Cell-mediated immunity plays a major role in the defense against monilial infections. Candida albicans can activate the complement system by the alternative pathway and produce small abscesses. Candidiasis affects only the outer layer of the mucous membranes and skin and occur in the mouth, vagina, uncircumcised penis, nail folds, interdigital areas, and large skin folds. The following table lists selected sites for candidiasis. C. albicans is highly adaptable in the human host environment, thus promoting its infection and colonization. So here are some common sites of candidiasis: the vagina, the penis, the mouth, skin folds. Hit pause. Pause, pause, pause. The initial lesion is a thin-walled pustule that extends under the stratum corneum with an inflammatory base that may burn or itch. The accumulation of inflammatory cells and scale produces a whitish yellow curd-like substance over the infected area. The lesion ceases to spread when it reaches dry skin. Topical antifungal medication is most commonly used for treatment. Vascular disorders. Vascular abnormalities are commonly associated with skin diseases. They may be congenital or may involve vascular responses to local or systemic vasoactive substances. Blood vessels may increase in number, dilate, constrict, or become obliterated by disease processes. Cutaneous vasculitis. Vasculitis is an inflammation of the blood vessel wall that can result in bleeding, aneurysm formation, or occlusion with ischemia, or infection of surrounding tissue. The extensive vascular bed in the skin results in vasculitis syndromes that may be localized and self-limiting, or generalized with multi-organ involvement. The initiating site may be the blood, the vessel wall, or adjacent tissue. Small vessels are usually unaffected, or usually affected, rather, sorry. Cutaneous vasculitis develops from the deposit of immune complexes in small blood vessels as a toxic response to drugs, or allergens, or streptococcal or viral infection, or as a component of systemic vasculitic syndromes. The deposits activate complement, which is chemotactic for neutrophils and other mediators of inflammation that disrupt adhesion molecules and the vessel wall. The disorder is also known as cutaneous small vessel vasculitis or cutaneous leukocytoclastic angiitis. The extremities are the chief sites affected primarily the lower legs and feet. The lesion may initially present with burning, itching, and pain. The pattern of skin involvement includes palpable purpures that may progress to hemorrhagic bullae, with necrosis and ulceration from occlusion of the vessel. Lesions appear in clusters and persist for 1 to 4 weeks. The disease may be self-limiting and occur as a single episode. Biopsy and direct immunofluorescence confirms the diagnosis. A systemic form can involve other organs, including the kidneys, lungs, and gastrointestinal tract. Identifying the primary disease or removing the antigen is the first step of treatment. Supportive treatment and topical steroids can relieve pruritus and burning. Systemic therapy and immunosuppressants are used when symptoms are severe. So here you're taking a look at the vasculitis of the leg. Urticaria, or hives, is a circumscribed area of raised erythema and edema of the superficial dermis. Urticaria lesions are most commonly associated with a type 1 hypersensitivity reaction to drugs, certain food, systemic diseases, or physical agents. They may occur with angioedema. The lesions are mediated by IgE-stimulated release of histamine, bradykinin, or kallikrein from mast cells or basophils, or both, which cause the endothelial cells of skin blood vessels to contract, increasing their permeability. IgG antibody directed against the IgE receptor and other inflammatory and vasodilatory substances, such as serotonin, leukotrienes, prostaglandins, and kinins, also may be mediators of urticaria. The leakage of fluid from vessels appears as veals, welts, or hives that may be distributed over the entire body. Most lesions resolve spontaneously within 24 hours, but new lesions may appear and a life-threatening reaction can occur. All possible causes should be removed. Antihistamines usually reduce hives and produce relief of itching. Corticosteroids and beta-adrenergics agonists may be required for severe attacks. Chronic urticaria is either idiopathic or autoimmune in origin, rarely because of allergy, and involves inappropriate activation of mast cells. Angioedema is associated with both groups and more commonly affects the eyes and the mouth. So here's a picture of urticaria. Sclerodema. Sclerodema. There are two categories of sclerodema. Localized sclerodema, or morphia, is usually benign and self-limiting and is confined to the skin and or the underlying tissue. Systemic sclerosis is characterized by cutaneous sclerosis with visceral involvement. Localized sclerodema means sclerosis of the skin and underlying tissue. The disease is rare, more common in females, and the cause is unknown. Genetic predisposition, autoimmunity, and an immune reaction to the toxic substance are possible initiating mechanisms of the disease. Your T helper cells, the Th1 and 17, and their cytokines are associated with fibroblast proliferation and fibrosis. Several autoantibodies also have been identified, including anti-nuclear antibody, antihistone antibody, and single-stranded DNA antibody. Impaired regulation of the collagen gene expression by fibroblasts probably underlies the persistent fibrosis. There are subtypes of localized scleroderma, but all involve thickening of the skin. Localized scleroderma is differentiated from the systemic form of the disease by the absence of the following: sclerodactyl Raynaud phenomenon, abnormalities of the nail bed, capillaries, or internal organ involvement. Systemic scleroderma involves the connective tissue of the skin and many organs, including the kidneys, gastrointestinal tract, and lungs. Fibrosis occurs in the papillary and reticular dermis and in the subcutaneous tissues and deep fascia. There are massive deposits of type 1 collagen with progressive fibrosis, accompanied by inflammatory reactions, as well as vascular changes in the capillary network, with a decrease in the number of capillary loops, dilation of the remaining capillaries, formation of the perivascular infiltrates, and development of occlusion and ischemia. The cutaneous lesions are the most often on the face and the hands, the neck, and the upper chest, although the entire skin can be involved. The skin is hard, hypopigmented, taut, shiny, and tightly attached to the underlying tissue. The tightness of the facial skin projects an immobile, mask-like appearance, and the mouth may not open completely. The nose may assume a beak-like appearance. The hands are shiny and sometimes red and edematous. The fingers become tapered and flexed, often with contractures, depressed scars, and loss of fingertips from atrophy. Progression to body organs can occur, and death is caused by subsequent respiratory failure, renal failure, cardiac dysrhythmias, or esophageal or intestinal obstruction or perforation. The clinical features of systemic scleroderma are summarized in the following box. So here is a picture of scleroderma. So note the inflammation and shiny skin. Here is a wonderful spot to hit pause on the clinical features of systemic scleroderma if you're unfamiliar with it. Suitable clothing and a warm environment are essential to protecting the hands. Trauma and smoking should be avoided. Treatment is individualized and based on organ involvement and the progression of the disease. Immunosuppressive medications, ultraviolet light treatment, and targeted therapies are prescribed. That leads us to our benign tumors. Most benign tumors of the skin are associated with aging. Benign tumors include seborrheic keratosis, keratocanthoma, actinic keratosis, and moles. Seborrheic keratosis. Seborrheic keratosis is a benign proliferation of cutaneous basal cells that produces smooth or warty elevated lesions. The pathogenesis is unknown. These tumors are usually seen in older people and occur as multiple lesions on the chest, back, and face. The color varies from tan to waxy yellow, flesh-colored, or dark brown lesions. Lesion size varies from a few millimeters to several centimeters, and they are often oval and greasy appearing with a hyperkeratotic scale. Both cryotherapy with liquid nitrogen and electrocautery are effective treatments, and the lesions usually slough 2 to 3 weeks after treatment. So here you're seeing the seborrheic keratosis. Keratoacanthoma. Keratoacanthoma is a benign self-limiting tumor of squamous cells differentiating arising from hair follicles. It usually occurs in sun-damaged skin of older adults and smokers. The incidence is high in males. The most commonly affected sites are the face, back of the hands, forearms, neck, and legs. The lesion develops over a period of 1 to 2 months and has a histologic course resembling a well-differentiated squamous cell carcinoma, as follows. The proliferative stage. The lesion develops as rapidly growing dome-shaped nodule with a central crust. The mature stage. The lesion fills with a whitish keratin and requires differentiation from squamous cell carcinoma. Involution stage occurs over a 3 to 4 months period with regression of the lesion. Although the lesions resolve spontaneously, treatment is optimal approach. They can be removed by curettage or excision to improve cosmetic appearance and reduce the risk of evolution to squamous cell carcinoma. Intralesional 5-FU, bleomycin, interferon, or methotrexate also have been effective. Actinic keratosis. Actinic keratosis is a common pre-malignant lesion composed of aberrant proliferations of epidermal keratinocytes caused by prolonged exposure to UV radiation. The prevalence is highest in individuals with unprotected, light-colored skin. Actinic keratosis is rare in black skin. The lesion appears as rough or scaly, poorly defined pink to reddish or reddish-brown papules that are felt more than seen, and are considered an early in situ squamous cell carcinoma. Surrounding areas may have telangiectasia, dermoscopy, and biopsy aid evaluation. Treatment options include ablative and photodynamic therapy, laser surgery, and topical therapies, such as 5-FU, diclofenac, imiquimod cream, and inguinal mebutate. The lesions should continue to be evaluated for progressive squamous cell carcinoma. Protection from the skin with clothing or sunblock to prevent lesion from developing elsewhere is advised. So here you take a look at the actinic keratosis. Nevi. Nevi, or moles, are benign pigmented or non-pigmented lesions that form from melanocytes beginning at ages 3 to 5 years. Melanocytic nevus, formed from melanocytes, may be congenital or acquired and small, or large. Larger congenital melanocytic nevus may be removed to reduce risk of cutaneous malignant melanoma. During the early stages of development, the cells accumulate at the junction of the dermis and epidermis and are macular lesions. Over time, the cells move deeper into the dermis, and the nevi become nodular and symmetric without irregular borders. Nevi may appear on any part of the skin and vary in size, occur singly or in groups, and may undergo transition to malignant melanomas. Nevi repeatedly traumatized, irritated by clothing, or considered too large may be excised. Multiple and changing moles require regular evaluation. So here we're taking a look at different types of moles, which leads us to our skin cancer. Skin cancer. Cutaneous basal cell carcinoma and squamous cell carcinoma are the most prevalent forms of cancer. Malignant melanoma is the most serious and the most common cause of death from skin cancer. Important trends related to skin cancer are presented in the following box. A great spot to educate yourself on the importance on trends for skin cancer. So hit pause. Chronic ultraviolet radiation causes most skin cancers. Lesions are most common of the face, neck, hands, and other areas exposed to intense sunlight. Protection from the sun and avoidance of tanning beds, particularly during childhood, significantly reduces the risk of skin cancers in later years. Genetic mutations in oncogenes and tumor suppressor genes are associated with skin cancers. This leads to loss of keratinocytes, repair functions, and apoptosis resistance of DNA-damaged cells. Dark-skinned persons and those avoiding sunlight are significantly less likely to develop these malignant tumors. In dark-skinned persons, basal cells contain the pigment melanin, a protective factor against sun exposure. You have basal cell carcinoma. Basal cell carcinoma of the skin is the most common cancer in the world, making it the most common skin cancer by default. Risk factors for basal cell carcinoma include chronic ultraviolet light exposure, radiation exposure, severe actinic damage, fair skin, radiation therapy, chronic arsenic exposure, long-term immunosuppression, and an older age. Basal cell carcinoma is a surface epithelial tumor of the skin originating from undifferentiated basal or stem cells. Basal cell carcinoma arises from mutation in the TP53 tumor suppressor gene, leading to a loss of keratinocyte repair functions and apoptosis, resistance of DNA-damaged cells. Other oncogenic pathways, including inhibition of the PTCH gene with overexpression in the sonic hedgehog signaling pathways. Your BCCs have numerous subtypes, including superficial, nodular, pigmented, morpheoform, and combinations of each. Thus, they can have very different clinical presentations, from superficial erythematous papules to thick, pigmented nodules resembling melanomas, to erosive, necrotic, and ulcerating lesions, and autosomal dominant basal cell nevus syndrome. The lesion often begins as a nodule that is purely or ivory in appearance and slightly elevated above the skin surface with a small blood vessel on the surface. The tumors grow upward and laterally or downward to the dermal epidermal junction. They usually have depressed centers and ruled borders. As the lesion grows, it often ulcerates, develops crusting, and becomes firm to the touch. So here we're taking a look at different types of basal cell carcinomas. Treatment includes complete surgical excision, radiotherapy, curettage, cryotherapy, photodynamic therapy, and topical applications of imiquimod or 5-fluorouracil. If left untreated, basal cell lesions invade surrounding tissue and over months or years destroy tissue. These are known as locally advanced basal cell carcinomas. Metastatic spread is rare because these tumors do not invade blood or lymph vessels. In LABCC or inoperable tumors, the smoothing receptor of the sonic hedgehog pathway can be inhibited by the use of vismodegib. Your cutaneous squamous cell carcinoma. Squamous cell carcinoma, or SCC, is a tumor of the epidermis with uncontrolled growth of keratinocytes and the second most common human cancer. Two types are characterized in situ and invasive. Ultraviolet radiation exposure causes SCC, and actinic keratosis is a precursor lesion. Other risk factors include genetic predisposition, chronic arsenic exposure, chronic non-healing wounds, radiation exposure, immunosuppression, and light-colored skin. Areas affected are the head and neck, and the hands, with 10% of squamous cell carcinomas occurring elsewhere on the body. UV exposure causes SCC, particularly mutation of the TP53 gene and other oncogenic signals. It is unclear how UV light produces alterations in DNA repair, and resistance to apoptosis. In situ, SCC is usually confined to the epidermis, but may extend into the dermis. Bowen disease is a dysplasia of the epidermis, or carcinoma in situ, found on exposed or unexposed areas of the body, such as the glans penis. The lesions are flat, reddish, scaly patches. These lesions may enlarge to more than 1 centimeter in diameter, rarely invading surrounding tissue, very rarely metastasize, and are associated with human papillomavirus. Other cellular components of the skin can give rise to SCC, but these cancers are relatively uncommon. Invasive SCC can arise from premalignant lesions of the skin. It rarely arises from normal appearing skin or de novo. Invasive SCC grows more rapidly than basal cell carcinomas, penetrates the basement membrane between epidermis and dermis, and can spread to regional lymph nodes with metastasis. These tumors are firm and increase in elevation and diameter. The surface may be granular and bleed easily. So here you're taking a look at the squamous cell carcinoma. SCC is the most common cause of lip cancer and is prevalent in older white men, with about 3,000 cases per year. The lower lip is the most common site. Long-term environmental exposure results in dryness, chapping, hyperkeratosis, and predisposition to malignancy. Immunosuppression, pipe smoking, and chronic alcoholism increases the risk for lip cancer. The most common lesion is termed exophytic and usually develops in the outer part of the lip, along with vermilion border. The lip becomes thickened and evolves to an ulcerated center with a raised border. These lesions have an irregular surface, follow cracks on the lips, and tend to extend toward the inner surface. So here's a picture of lip cancer. Treatment includes cryotherapy, 5-FU, and a photodynamic therapy for small, low-risk superficial SCC, and complete microsurgical excision with histologic analysis, and radiotherapy, with consideration of adjuvant chemotherapy for advanced disease. Cutaneous melanoma. Cutaneous melanoma is a malignant tumor of the skin originating from the transformation of melanocytes, the cells that synthesize the pigment melanin and arise from the neural crest. Melanoma is the most serious skin cancer, with an estimated 87,110 new cases and 9,730 deaths in the US in 2017. Non-cutaneous melanoma is rare but is most common in the uvea of the eye and in mucous membranes. The incidence of melanoma is increasing in the United States and worldwide. There is uncertainty regarding how much of the increase is attributable to greater melanoma screening activities, potential detection bias, and overdiagnosis. However, discovering melanoma at an early stage increases a 5-year survival. Risk factors include person and or family history, or both, solar and artificial ultraviolet light exposure, immunosuppression, fair hair, light skin with repeated sunburns, freckles, younger females and older males, geographic location, past pesticide exposure, and 3 or more clinically atypical melanocytic nevi. Multiple melanocytic nevi are associated with non-chronic sun-damaged melanomas and BRAF mutations and occur more commonly on trunk and extremities. Melanoma is the most common cancer in white women 25 to 29 years of age. Cutaneous melanomas arise as a result of chronic sun exposure or pathways associated with melanocytic nevi, resulting in malignant degeneration of melanocytes located either along the basal layer of the epidermis or in the benign melanocytic nevus. They grow vertically, eventually penetrate the endothelium of capillaries and enter the bloodstream and lymphatics, allowing them to form distant metastases. The clinical types of cutaneous melanomas are based on the histologic growth pattern. Melanomas in situ are in a radial growth phase and include superficial spreading melanoma, the most common, with radial growth preceding vertical growth. Lentigo, malignant melanoma, frequently found in the elderly and confused with age spots and an aggressive vertical growing tumor, and acral lentigious melanoma. It is rare and it is rare and aggressive and occurs on non-hair-bearing surfaces and in mucous membranes, more commonly in Black and Asian people. Primary nodular melanomas are in a vertical growth phase and are more aggressive, rare, difficult to diagnose. Subtypes include desmoplastic melanoma, which resemble a scar, and amelanotic melanoma tumors. So here we're taking a look at malignant melanomas. The pathogenesis. The pathogenesis of malignant melanoma is complex. It is an accumulation of genetic mutations that activate oncogenes, inactivate tumor suppressor genes, and impair DNA repair genes. The most familial melanomas are associated with cyclin-dependent kinase 4 gene and cyclin-dependent kinase inhibitor 2A gene, located on chromosome 9p21. The CDKN2A gene encodes two potent tumor suppressor proteins, P16 and P14ARF, that are cell cycle inhibitors. Both CDKN2A and CDK4 are highly penetrant susceptibility genes and resultant in melanomas. A number of proto-oncogenes have been identified, including BRAF point mutations and NRAS, and genes involved in the regulation of mitogenic activation protein kinase and other signaling pathways. Melanomas have a high mutation rate, stimulated by UVR, making gene sequencing difficult. The relationship between nevi and melanoma makes it important for the clinician to understand the various naval forms. Most nevi never become suspicious. However, suspicious nevi should be evaluated and removed. Indication for biopsy include changes in color and size, irregular notched margin, itching, bleeding, or oozing, nodularity, scab formation, ulceration, or an unusual pattern and presentation. The ABCDE rule is used as a guide. A. Asymmetry. B. Border irregularity. C. Color variation. D. Diameter larger than 6 millimeters. And E. Elevation, which includes raised appearances or rapid enlargement. Clinical characterizations or clinical characteristics are summarized in the following tables here. So here are different classifications of nevi: the junctional nervous, the compound nervous, and the intradermal nervous. Nevus. It's nevus, not nervous. I'm sorry. And then clinical characteristics of subtypes of cutaneous melanoma. So here are again good spots to pause. Surveillance strategies include clinician-based total body skin examination, total body photography, dermoscopy that may be combined with confocal microscopy, and individual-based self-skin examination. Staging of melanoma is determined using tumor node metastasis criteria established by the American Joint Committee on Cancer and is summarized in the following box. Again, a good spot to hit pause if you are unfamiliar. Prognostic factors include the thickness of the lesion, mitotic index, immunohistochemical assessment, ulceration, and metastasis. Efforts are in progress to refine the morphologic classification by adding subgroups that include molecular markers for proto-oncogene mutations and specific signaling pathways. Early detection of cutaneous melanomas can have a major effect on achieving a surgical cure and decreasing mortality from metastatic disease. Prevention of melanoma include avoidance of UV radiation exposure through use of protective clothing and sunscreens, and avoidance of artificial UV radiation exposure. Treatment of melanoma with no evidence of metastatic disease involves wide surgical excision of the primary lesion site. A lymph node biopsy of the periphery draining lymph node is warranted for lesions greater than 1 millimeter deep, and, if positive, regional lymphadenectomy is performed. Lesions on the extremities have the best surgical prognosis. Immediate complete lymph node dissection increases the rate of regional disease controlled and provides prognostic information, but does not increase melanoma-specific survival among individuals with melanoma and sentinel node metastasis. There also is significant morbidity associated with residual lymphedema. Survival rate for advanced disease is very low. Radiation therapy, chemotherapy, and immunotherapy, inhibiting the MAPK pathway and BRAF mutation, and MEK inhibition are used to treat metastatic disease and have demonstrated long-term improvement in disease outcome. Promising new immunotherapies are used for advanced disease, including checkpoint inhibitors, programmed cell death protein 1, receptor antibody, anti-CTLA4 antibody, and targeted therapy, including BRAF and/or MEK inhibition, c-KIT gene inhibitors of tyrosine kinases, and platelet-derived growth factor. Vaccines, cell therapy, and biomarkers are assessed. Treatment effectiveness are under continued investigation. Merkel cell carcinoma. Merkel cell carcinoma is a very rare, aggressive cutaneous carcinoma, usually localized to the head and neck. Risk factors include ultraviolet radiation, immunosuppression, age older than 50, male, gender, and Merkel cell polyomavirus infection. The lesion appears as nodules or skin-colored or purple domed shaped papules or plaques. Treatment include wide excision and adjuvant radiotherapy. Targeted therapies are being evaluated. Mortality is high for metastatic lesions. Kaposi sarcoma. Kaposi sarcoma is a vascular malignancy associated with immunodeficiency states and occurs among transplant recipients taking immunosuppressive drugs. Genetic and environmental cofactor determine disease progression. Human herpes virus type 8 is found in all lesions of Kaposi sarcoma. 4 forms of the disease have been described: classic, epidemic, African endemic, and iatrogenic. The endothelial cell is thought to be the progenitor of Kaposi sarcoma, with inflammation and angioproliferation. The lesions emerge as purplish-brown macules and develop into plaques and nodules. They tend to be multifocal rather than spreading by metastasis. The lesions initially appear over the lower extremities in the classic form. The rapidly progressive form associated with AIDS tends to spread symmetrically over the upper body, particularly the face and oral mucosa. The lesions are often pruritic and painful. About 75% of individuals with epidemic Kaposi sarcoma have involvement of lymph nodes, particularly in the lung and gastrointestinal tract. Organ involvement is much less common in classic form. The rapidly progressive form has poor prognosis and shorter survival rates than the classic form. So here's a picture of Kaposi sarcoma. Diagnosis is by the medical history, physical exam, and skin biopsy, with a high index of suspicion for those with immunodeficiency. Chest imaging reveals lesions in the lungs, and endoscopy is completed if there is suspicion of gastrointestinal involvement. Local lesions can be excised. Multiple disseminated lesions may be treated with a combination of an alpha interferon radiotherapy and cytotoxic drugs. Anti-angiogenic agents are being tested. Individuals receiving highly active antiretroviral therapy have a marked reduced incidence of Kaposi sarcomas. Your primary cutaneous lymphomas. Primary cutaneous lymphomas are cutaneous T-cell and B-cell lymphomas that are present in the skin without evidence of extracutaneous disease at the time of diagnosis. Cutaneous lymphomas are rare, but are the second most common site of extranodal non-Hodgkin's lymphoma. The incidence rate is about 14 per 100,000, and their cause is unknown. Cutaneous lymphomas are more common in men and generally present after age 50. 75% of cases are T-cell lymphomas and 25 are B-cell lymphomas. Cutaneous lymphomas develop from clonal expansion of B cells, T helper cells, and rarely T suppressor cells. The most common is cutaneous T-cell lymphoma, and mycosis fungoides is the most prominent subtype. Sézary syndrome and primary cutaneous CD30 positive lymphoproliferation are the most aggressive. Mycosis fungoides can present as focal or widespread erythematous patches or plaques, follicular papules, cum-dun-like lesions, and tumors. Lesions are pruritic and cause considerable distress and debilitation. There may be patches of alopecia. The lesions progress over a period of months or even years. Involvement of other organs can occur in advanced stages of the disease. So here are some pictures of our mycosis fungoides. The differential diagnosis of the different types of cutaneous lymphomas is based on the clinical manifestations, skin biopsy and histology appearance, immunologic and cytogenic features, and response to appropriate treatment. Treatment is based on staging of the disease, following census-based guidelines that include a range of topical and systemic therapies, such as anti-inflammatory, immunomodulatory, and biologic agents, histone deacetylase inhibitors, rexinoids, phototherapy, and chemotherapeutics. Radiotherapy has historically been the most common successful therapy. Stem cell transplant is the only cure for cutaneous T-cell lymphoma. That leads us now to cold injuries. Exposure to extreme cold includes a spectrum of injuries. Frostnip, mild and completely reversible injury characterized by skin pallor and numbness. Chilblains, more serious injury than frostnip, violaceous skin color with plaques or nodules, pain and pruritus, but no ice crystal formation. Chronic vasculitis can develop and is usually located on the face, anterior lower leg, hands, and feet. Frostbite, tissue freeze and form ice crystals at temperatures less than -2 degrees Celsius, progressing from distal to proximal, is potentially reversible. And then flash freeze, Rapid cooling with intracellular ice crystals associated with contact with cold metals or volatile liquids. The most common areas affected are fingers, toes, ears, nose, and cheek, and skin damage can range from mild to severe. Initially, the body responds with alternating cycles of vasoconstriction and vasodilation, the hunting reflex. The mechanism of injury is complex, but is related to direct cold injury to cells, indirect injury, cell death from extracellular and intracellular ice crystal formation, impaired circulation with anoxia because of thrombosis in the exposed area, and reperfusion injury. Mild frostbite causes pallor and pain, followed by redness and discomfort during rewarming with no tissue damage. Frozen skin becomes white or yellowish and has a waxy texture. There is numbness and no sensation of pain. Frostbite injury is related to direct cold injury to cells, indirect injury from ice crystal formation and endothelial cell damage. During rewarming, there is progressive microvascular thrombosis, followed by reperfusion injury with release of inflammatory mediators, and with impaired circulation and anoxia to the exposed area. Cyanosis and mottling develop, followed by redness, edema, and burning pain on rewarming in more severe cases. Edema can cause capillary compression and vascular stasis. Within 24 to 48 hours, vesicles and bullae appear and resolve into crusts that eventually slough off, leaving thin, newly formed skin. The most severe cases result in gangrene with loss of the affected part. Frostbite may be classified by depth of injury after rewarming as follows. A first degree, a superficial characterized by numb central white area surrounded by erythema and edema, and including partial skin freezing without blistering. A second degree, full thickness skin freezing with blistering surrounded by edema and hyperemia. Third degree, deep, characterized by full thickness skin and subcutaneous freezing with tissue necrosis and hemorrhagic vesicles and blisters. Fourth degree, deep tissue freezing with full thickness necrosis and gangrene with a line of demarcation. Immediate treatment of frostbite is to cover affected areas with other body surfaces and warm clothing. The area should not be rubbed or massaged. Rewarming for severe frostbite should occur after emergency transport. Immersion in warm water bath until frozen tissue is thawed is the best treatment. Pain is severe and should be treated with potent analgesics. Antibiotics may be given. Vasodilators, thrombolytics, hyperbaric oxygen, and sympathectomy may improve healing responses. Debridement or amputation of necrotic tissue occurs when there is a clear line of demarcation. Leading us to disorders of the hair. Alopecia. Alopecia means loss of hair when the head or from the head or body. Hair loss occurs when there is a disruption in the growth phase of the hair follicle. Hair loss can be associated with systemic disorders such as hypothyroidism and iron deficiency, chemotherapy for cancers, malnutrition, compulsive hair pulling, traction on hair from braiding and ponytails, use of hair treatment chemicals, hormonal alterations, and immune reactions. Androcentric alopecia. Androcentric alopecia is localized hair loss and occurs in about 80% of men and 50% of women with alopecia. It is not a disease, but rather a variation in the androgen receptor gene that clusters in families. The mechanism of inheritance is unknown. Within the distribution of hair over the scalp, androgen-sensitive hair follicles are on top and androgen-insensitive follicles are on the sides and back. In genetically predisposed men, the androgen-sensitive follicles are transformed into vellus follicles. The normal hair is shed and replaced by fine, light, short hair. Male pattern baldness begins with frontotemporal recession and progresses to loss of hair over the top of the scalp. Minoxidil may be used to stimulate hair growth, and finasteride may decrease the effects of androgen on hair follicles. Affected individuals may choose to wear wigs or have hair transplants. Female pattern alopecia. Women in their 20s and 30s and women older than 70 years experience thinning and loss of hair over the central, frontal, and parietal scalp region. Often there is a family history and earlier presentation. Hair follicles are miniaturized and less functional with a reduction in hair density. Many of these women have elevated levels of serum androgen, dehydroepiandrosterone sulfate, and treatment with anti-androgens can be effective. Lower levels of estrogen can also decrease hair growth after menopause. Minoxidil and light therapy, or a combination of therapy, may be used and work best when started early. Finasteride is no more effective than placebo. In rare instances, male pattern baldness develops. Lab evaluation of serum androgenic hormones show elevations, and some women have decreased hair loss when treated with daily doses of spironolactone. Alopecia areata. Alopecia areata is an autoimmune T-cell mediated chronic inflammatory disease directed at hair follicles that result in hair loss. Hair loss occurs in multiple areas of the scalp. The eyebrows, eyelashes, beard, and other areas of the body can be involved. The cause is unknown, but stressful events, cell-mediated immune factors, and genetic susceptibility are linked to hair loss. Other autoimmune diseases such as Addison's disease, thyroid disease, and lupus erythematosus also are associated in some individuals with alopecia areata. The affected areas have round or oval areas of hair loss that may coalesce. The skin is smooth and may have short shafts of poorly developed hair that breaks at the surface. Regrowth occurs within 1 to 3 months, but hair loss may recur at the same site. Permanent regrowth of hair usually occurs. Total loss of hair occurs in some young people. The long-term prognosis for total hair regrowth is poor. Diagnosis is made by observation of the pattern of hair loss. Biopsy may show a lymphocytic infiltrate around the follicle. There are several treatments for alopecia areata, including watchful waiting, topical and intralesional corticosteroids, light therapy, minoxidil, and topical immunotherapy. Hirsutism. Hirsutism is the abnormal growth and distribution of hair on the face, body, and pubic area in male patterns that occur in about 5 to 10% of women. There is also frontotemporal hair recession. These areas of hair growth are androgen sensitive. Variation of hair growth in women are great, and male pattern can be normal. Women who develop hirsutism may be secreting hormones associated with ovarian or adrenal disease, and they should be evaluated for polycystic ovaries, adrenal hyperplasia, or adrenal tumors. If no hormonal pathologic condition exists, undesirable hair can be removed mechanically by electrolysis or with lasers. Endocrine therapy to suppress androgens may be considered. Disorders of the nail. Paronychia. Paronychia is an acute or chronic infection of the cuticle. One or more fingers or toes may be involved. Individuals whose hands are frequently exposed to moisture are at greatest risk. The most common causative microorganism are Staphylococcus or Streptococcus, and occasionally Candida. Acute paronychia is manifested by the rapid onset of painful inflammation of the cuticle, usually after minor trauma. The skin around the nail becomes more edematous and painful with progressive infection. Pus may be expressed from the proximal nail fold, and an abscess may develop, requiring incision and drainage for pain relief. The nail plate is usually not affected, although it can become discolored with ridges. Chronic paronychia develops slowly, with tenderness and swelling around the proximal and lateral nail folds. Treatment includes prevention by keeping the hands dry and avoidance of predisposing factors, such as trauma through cuticle manipulation or excessive manicures. Oral antifungals are not effective because they do not penetrate the affected tissue. Several topical agents are available. Onychomycosis. Onychomycosis is a fungal or dermatophyte infection of the nail unit. The most common pattern is a nail plate that turns yellow or white and becomes elevated as a result of an accumulation of hyperkeratotic debris. Onychomycosis. Onycho- Onychomycosis is a fungal or dermatophyte infection of the nail unit. The most common pattern is a nail plate that turns yellow or white and becomes elevated as a result of an accumulation of hyperkeratotic debris within the plate. Fungal infections of the nail are differentiated from psoriasis, lichen planus, and trauma by culture and microscopy, and the absence of pitting on the nail surface, which is characteristic of psoriasis. Treatment is difficult because topical or systemic antifungal agents do not penetrate the nail plate readily. Two topical agents, efinaconazole and tavaborole, have been approved and are applied for 12 months. Terbinafine is an effective systemic antifungal drug. Surgical excision of the nail may be required. Education is essential to preventing recurrence. And that concludes our chapter today. I thank you all for watching, and I'll see you all next time. Till then, stay safe and take care.